both the short PR interval as well as the long PR interval. And we were talking about the QRS complex. We mentioned what a normal QRS complex looks like. So in the limb leads, all the QRS are either positive or equiphasic, except for ABR, which is totally negative. And we also mentioned that in the chest leads, there will be a continuous progression of the R wave from V1 to V6, which is called the normal progression of the R wave. We went on to mention that we talk about the morphology of the QRS complex, where we discuss about the hypertrophy and the bundle branch block. So we also discussed the hypertrophy, both the left ventricular as well as right ventricular hypertrophy. We mentioned that LVH is always the exaggeration of normal. So in V1, when you have a small r and a deep S wave, in LVH, the S wave becomes extremely prominent, very deep. Whereas in RVH, the opposite occurs, where the R wave becomes prominent and the S wave becomes small. Similarly, in V6, we mentioned it's a small Q with a tall R wave. And in LVH, there is exaggeration, so the R wave becomes extremely prominent, a tall R wave, versus in a patient with right ventricular hypertrophy, where the negative forces become dominant, so the S wave becomes dominant. So this is where we were. Then after we talk about any questions or any comments on whatever we discussed in ECG till now? Anyone needs any repetition or any aspect of it which you have not understood? Okay, so after LVH and RVH, we move on to the bundle branch block. So when we talk about bundle branch block, generally, again, this is something where people get worried, confused, and they are not sure what exactly is happening in the ECG. Now, the problem there arises because there is too much of emphasis put on the receptor level about the branches, the depolarization, how it occurs, how the repolarization changes, so on and so forth. And that produces a lot of confusion in the mind. Now, the diagnosis of bundle branch block on the ECG fundamentally depends upon pattern recognition. So, what happens at the cellular level and what happens at the bundle level in the heart is another aspect of it. But that you need not worry as far as interpretation in the ECG is concerned. So, how do you interpret the ECG? Whenever the QRS you want to know, similar to what we told in P wave, that we look at lead 2 and we look at lead V1. Similarly, whenever you want to look at the bundle branch block, there are few leads which you look at. So you look at L1, you look at AVL, you look at V1, and you look at V6. Okay, so those are the leads which you try to look at for pattern recognition. So what happens in RBBB and what happens in left bundle branch block? So remember that in L1 and AVL, in right bundle branch block, you will have a slurred S wave. Okay, so you have a slurred S wave in right bundle branch block in L1 and AVL. In V1, you have the famous RSR pattern. And in V6, the opposite of RSR occurs. So you have the QRS pattern. Okay, whereas in left bundle branch block, the opposite occurs. So in L1, instead of having a slurred S wave, what you have is a slurred R wave. Similarly, in AVL, you have a slurred R wave. In V1, you have the typical W pattern, and in V6, you have the M pattern. Okay, so that is the left bundle branch block and right bundle branch block. So L1 and AVL slurred S wave in RBBB, whereas slurred R wave in L1 and AVL in LBBB, RSR pattern in V1 in RBBB, and QRS pattern in V6 in RBBB, versus a W pattern in V1 in LBBB and a M pattern in V6 in LBBB. Now, this pattern recognition is fundamental. So once you have a broad QRS complex, you look at L1, AVL, V1, and V6, decide whether it is fitting into a right bundle branch block pattern or it is fitting into a left bundle branch block pattern. If the limb leads are suggestive of one pattern and the chest leads are suggestive of the opposite pattern, then it is called as a intraventricular conduction disturbance, IVCD. Or if it is not fitting into any pattern, that means based on this L1, AVL, V1 and V6, you are not able to differentiate whether it is RBBB or LBBB, then it is again an intraventricular conduction disturbance. Okay. So once you have a broad QRS, you decide whether it is RBBB pattern or LBBB pattern. If it's both RBB and LBBB, one in limb leads, one in chest leads, then it is IVCD. Or neither of the two, then again it is a intraventricular conduction disturbance. So these ECGs actually show you the same pattern. So if you look at a normal ECG, okay, so L1 you can see the QRS complex, AVL you can see the normal QRS complex. V1 we said normally you'll have a short small R wave and a deep S wave and a small Q wave and a tall R wave in V6. So this is your normal pattern. In right bundle branch block, we mentioned that the S wave in V1, L1 and AVL. So you can see that the S wave in L1 and AVL is prolonged. And in V1, you have the RSR pattern. And in V6, you have the QRS pattern. Yes, so that is the RBBB pattern. LBBB, we said the R wave is slurred. So there is a prolongation of the R wave in L1 and AVL. And there is a W pattern in V1 and a M pattern in V6. Okay. So is this clear? The pattern recognition of right bundle branch block and left bundle branch block. So if you look at this ECG, we know that this QRS is prolonged. So once it is prolonged, we are looking at L1, we are looking at AVL, we are looking at V1, and we are looking at V6. So you can clearly see that the R wave is prolonged in L1 and AVL. The R wave is prolonged. And here there is a prolongation of the S wave, though classical W pattern is not there. And here you can see like a half M pattern. Okay, so the R wave is prolonged in V6. So this fits into the left bundle branch block type of pattern. So this is a LBBB. Now here if you look at, you can see that again there is a prolonged QRS complex, but the S wave in L1 is prolonged here. There is a S wave in AVL which is prolonged. You have the RSR pattern. Okay, so you have the R and you have the S and again the R. So that is the RSR pattern in V1, and then the small Q followed by R and S. So QRS pattern in V6. So this will fit into the right bundle branch block type of pattern. Okay, so that's how you differentiate whether it is a LBBB or a RBBB. Okay, so any questions on this about LVH, RVH, right bundle branch block and left bundle branch block? So what you do is after the class, just on a paper, you draw the pattern. If you draw the pattern, that will get imprinted in your mind. Then you can remember very clearly what exactly is the pattern recognition. And then the moment you see the ECG, you are able to identify that particular pattern. Okay. So after QRS complex, we come to the ST segment. So the most important aspect of this talk in the whole of ECG is the ST segment, because missing something in the ST segment can kill the patient. So you might lose the patient just because you could not identify a ST elevation. Okay, so ST segment is the most important aspect. So as we already mentioned, ST segment, when we say it is from the end of the QRS complex to the beginning of the T wave, because it is a segment, it is between the two waves. Okay. Now, when you look at the ST segment, a fundamental concept which you should understand is the concept of current of injury. So remember that current of injury always goes from the normal to the abnormal segment. Okay, so from the normal, the current goes towards the abnormal segment. So if you have a ischemia in which it is subendocardial, then the current from the outer side goes towards the inner side. That means the current from the epicardial side goes towards the endocardial side, because only part of the myocardium is ischemic now. So when you have a lead here, we said whenever the current is going away from the lead, it will produce a ST depression. So if you put a normal baseline and the ST has come down here, so this is the extent of ST depression. Whereas if you have a transmural infarct, or what we call the ST elevation myocardial infarction, where the whole of muscle is infarcted, the current is coming from the other side towards the infarcted side. So the current is coming towards the infarcted segment. Similarly, this acts like a window. So the current from behind also is coming towards the infarcted segment. So this produces, because the lead is now facing the current of injury, it produces the ST elevation. So this is the normal segment. This is the baseline. So normally this ECG, the R wave should have come down till here and then come like this. But here it is not come here. It has gone up from here. So this extent is the extent of ST segment. So first you identify whether there is any ST depression or ST elevation. Then you find out in how much it is, what is the type of ST elevation or ST depression, and in which areas those ST depression and ST elevations. So this is the concept of current of injury, which is very important for you to localize. So any place where the injury has occurred, if the whole myocardium has got injured, that will produce ST elevation in that particular area. Whereas the opposite area will produce the ST depression. Okay, so that's the concept of current of injury. So what are the types of ST elevation? So you can have convex upwards ST elevation. You can have a straight upsloping ST elevation. You can have a straight horizontal ST elevation. You can have a straight downsloping ST elevation, or you can have a concave upwards ST elevation. The concave upwards ST elevation is important because that might indicate pericarditis. So there can be some non-ischemic causes of ST segment changes. So one of them is pericarditis. So concave upwards is produced in patients who have developed pericarditis. Now these are the different patterns which you can have in ST elevation. So this is a QR pattern. Okay, so you have a QR wave and then the ST elevation. Then this is a RSR pattern with ST elevation. Okay, then you have QR, a small s has started, and then you have ST elevation. There can be different phases in which ST elevation can occur. So a very tall T wave with ST elevation is a hyperacute stage when the myocardial infarction is just starting. Then you can have a proper ST elevation, and slowly the ST elevation can come down. Now you might be thinking why this guy is spending so much of time in trying to tell us QR ST elevation. ST elevation is ST elevation, it doesn't matter. So one of the reasons why we are spending so much time in trying to explain to you this is many a time this type of ST elevation can be mistaken for a broad QRS complex. So people might think it is just a broad QRS complex when it is actually ST elevation. We'll show you some ECGs like that, where it is mistaken for a broad QRS complex. I know you won't be still believing me when I tell you that the broad QRS ST elevation is mistaken for broad QRS. We'll show you some ECGs and then you'll realize how not uncommonly you can commit that mistake. Okay, so those are the different types of ST elevation which you should be aware of. Now, once you know that there is a ST elevation or ST depression, the next is you find out in which area it is. So how do you identify the area? So we mentioned that L1 is totally horizontal. Okay. So L1 is from the right arm to left arm. So it is lateral. So the heart is like this and this is the lateral wall. Okay. So L1 will indicate lateral problem. Okay. Then L2. L2 is downwards. So L2 will be inferior. L3 is again downwards. So it will be inferior. AVR is towards the right arm. So it is often called the orphan lead because everything will be opposite and hardly anyone bothers about AVR, except in situations like left main stenosis and all, which again we'll show you, where you can have ST elevation in AVR. Okay, so other than that, almost AVR is practically of no use. Okay, AVL again is towards the left arm, so it is lateral. So L1 and AVL are lateral. AVF is downwards. Okay, so L1 AVL will become lateral. Okay, so you have L1 and AVL, which will be lateral ischemia or lateral wall MI. You have L2, L3, and AVF, which will indicate inferior. Okay. Then you have anterior. So anterior, we said it starts with V1 and then starts moving laterally. So V1, V2, V3, V4, V5, V6. And previously, V1, V2 were considered septal and V5, V6 were considered anterolateral, but nowadays those terms are not used. So V1 to V6, they are considered to be anterior. Okay, there are certain other terminologies which we'll again come to, like posterior and all. When we are showing you the ECGs, we'll talk to you about what is posterior, what is true posterior, what is extensive anterior, and the other terminologies which are used in ST elevation. Okay. Now, after ST elevation, you talk about ST depression. So ST depression again can be of three types. You can have a horizontal downsloping ST depression. You can have a upsloping ST depression. You can have a flat ST depression. Okay, so this is the baseline as is shown here, and this is the extent of ST depression. So it can be either upsloping, or it can be downsloping, or it can be flat. Now, one of the reasons why you tend to differentiate these types of ST depression is upsloping ST depression could be a normal variant. So it may not be, of course, if patient has angina, you have those changes, then again it is important. But in a normal person, you suddenly see some ST upsloping ST depression, especially in women, then you need not really worry about it. It could be just a normal variation. Whereas flat ST depression or a downsloping ST depression almost always indicates that there is a significant ischemia which is going on. Similarly, when you do a treadmill test, so you do an exercise test, you make the patient walk, and then you record the ECG. In that, again, upsloping ST depression may not be that important, but a downsloping ST depression or a flat ST depression is extremely suggestive of underlying obstructive coronary artery disease. So, differentiating the types of ST depression will be helpful in trying to find out if it's something important or not important. So anything anyone wants to ask about ST depression and ST elevation before we go to T wave inversions? Sir, you would like to add something?
Nothing, Rajiv. Thank you.
Kumar sir?
Nothing, Rajiv.
Okay, so after ST segment, we'll go on to T waves. Okay. So when we all know that T waves indicate ventricular repolarization. So till now QRS and all we were talking about ventricular depolarization. Then T wave indicates ventricular repolarization. So there are different morphologies of T waves which you should be aware of, which will help you in identification. So if you look at the normal T wave, you can see that it has a smooth upslope, downslope, and the kind of slightly upper end is slightly peaked. Okay, you can have a biphasic T wave which appears like this. You can have a notched T wave. You can have a broad and slightly low amplitude T wave. You can have a flat T wave. So flat T wave, again, as we mentioned, we said when the current is exactly perpendicular to the lead, then you can have either a equiphasic or a flat. So the T wave can be equiphasic or the T wave can be totally flat. That is, it is absent. Then you can have a tall peaked T wave. So that is indicative of hyperkalemia. So you can see here that it is tall and peaked. Now, what is important here is to understand the morphology of peaking. So you can see that it's almost like the pencil tip, right? So the peak which is there, when it is so acute and shows so sharp, even though the amplitude is not much, this will give you a clue that the patient might be having hyperkalemia or the patient is having a hyperacute myocardial infarction. Then you can have a prolonged QT interval with the broad T wave. Then there are variations of T wave. Lot of T wave abnormalities may not be ischemia related. They could be related to what we call as reciprocal changes. So when patient has left ventricular hypertrophy, patient has pre-excitation, patient has bundle branch blocks, it just reflects the opposite of what the QRS shows. Now, one of the things which we mentioned to you was left ventricular hypertrophy and strain pattern. We said you'll have a tall R wave, then you have a ST depression, and you have an inverted T wave. Now you look at this pattern of strain where you'll have the ST depression and the inverted T wave, but you see both the limbs of the T wave. Okay, one limb is prolonged, whereas the other limb is abbreviated. So it is asymmetrical. The T wave inversion is asymmetrical, one being long and one being short. Versus if you have ischemia as the cause of T inversion, you can see that it is a symmetrical T wave inversion. Okay, so that helps in differentiating ischemia from many other causes of T wave inversion. Then we mentioned about early repolarization, or in hyperacute MI, you can have a very tall P wave. In early repolarization, what happens is that there is a J point elevation. So this is the baseline. The end of the QRS is the J point. Now you can see that the J point has gone up. So this could be just a normal variant, and from there the T wave picks up. So J point elevation is indicative of early repolarization. Previously, it used to be thought that all early repolarization are absolutely benign. We need not worry about it, but we know now that not all early repolarizations are benign. They can cause some sudden cardiac arrest. It could be an early sign of ischemia. So all those things we need to remember. Okay, so those are the different morphologies of T wave which you should be aware of. This is an example of a tall peaked T wave. So you see the QRS complex and you see the T waves, how big they are. And you can see the morphology here. It's almost like a peaked T wave. So these are tall peaked T waves. Now, after you talk about the T wave, the last thing you mention about in the ECG is the QT interval. So the QT interval, because we said it is an interval, it is from the beginning of the Q wave to the end of the T wave. Okay, generally the QT where you have the longest QT in the ECG, that is taken as the QT interval, the longest QT interval. So from the beginning of the QRS complex to the end of the T wave is referred to as the QT interval. Now QT interval can be misleading when the heart rates are slow or when the heart rates are fast. So for that, the Bezet's formula was formulated to do the correction for QT interval. So that is called as QTC, that is corrected QT interval. So corrected QT interval is given by QT interval divided by square root of RR interval. Okay, so you take the QT from the beginning of the QRS complex to the end of T wave, and then you take the RR interval and you divide the QT interval divided by square root of RR interval. So this is an example. You can see obviously that there is a prolongation of the QT interval. Now, one rule of thumb which we use every day, because for every case trying to calculate the corrected QT will be difficult. So one rule of thumb is if the QT interval is more than 50% of RR interval, it indicates that the QT interval is prolonged. So say, let's take this particular lead, and you can see that there is 1 R here, 1 R here. This is the RR interval, and you take 50% of RR interval. You can see that obviously the QT, this is the QT interval. The QT has gone beyond 50% of RR interval. Here you can also see some alternates of QT. You can see here this T wave is inverted, T wave is upright, T wave is inverted, T wave is upright. So this is referred to as the QT alternates or the T wave alternates, where one beat shows negative and the other beat shows positive. So now let us take this example and try to calculate the QT interval in this particular case. So Bezet's formula, we said QTC is QT divided by square root of RR interval. Now QT is how much? Now let's see how many large squares. So this is 1, 2, 3, 4. Okay, so QT interval, QT is 1, 2, 3. Okay, so almost here. There are 3 large squares for the QT interval. So QT is 15 into 0.04, that is 0.6 milliseconds. We said 0.6 seconds. So we said 40 milliseconds is one small square. So here it is 15. So 15 into 0.04 is 0.6. Then RR interval is 20. We mentioned here, you can see here, this is 1, 2, 3, 4. Okay, so 4 large squares is the RR interval. So 20 into 0.04 is 0.8. So you would take the square root of RR. So you take the square root of 0.8. So what is the square root of 0.8? Those with whom I already discussed, you need not tell the answer. Others can tell the answer. I think people are fresh from physics, mathematics and all. No? Yeah. Third year MBBS, fourth year MBBS. You should be able to tell us what is the square root of 0.8? Two 2.8. Okay. Anyone else has any other answers? So Anaga said 0.9. So that's the correct answer. Actually, this question I think we've been asking for more than 20 years now. And the number of people who have answered are less than 2 or 3. So they give all types of answers, 0.4 to 0.6 to uh, uh, again 0.8, all answers. So the square root of 0.8 is 0.9. I am sure you are still not convinced. So if you say 0.9, 0.9 into 0.9 is equivalent to 0.81. Okay, so that's why the square root of 0.8 is 0.9. Okay, so I think all of you are might be feeling proud that you took medicine and didn't continue in mathematics. So the square root of 0.8 is 0.9. So here the QTC will now be 0.6 divided by 0.9. So it is 0.66. So it is grossly prolonged. We said more than 0.44 is a prolonged QT interval. So here it is almost 0.66. So that's how you calculate the QT interval. So now having told all these things, you need to
Rajiv,
describe.
I want to add here the QT prolongation and QTC calculation, various formulas are available, but none of them are accurate. At higher heart rates, you overestimate it, and lower heart rates, you underestimate it. Always take the clinical circumstance into consideration and electrolytes and underlying condition, etc. Keep it in mind.
Yes, sir. So now we have described a normal ECG. We took almost 3 classes to make you understand how you describe the normal ECG. So after you have described, you should know how you put it on paper. Okay, so you know how to identify the abnormalities, but you need to put it on paper. So when you describe a normal ECG, suppose every day you are seeing a ECG which is totally normal, you just don't tell normal ECG. You are supposed to tell all these things. Okay, so you say ECG of so and so taken on so and so date and time. It is normal standardization, heart rate of whatever it is, normal sinus rhythm, normal axis, P wave is normal, PR interval is normal, QRS is normal, ST segment is normal, T wave is normal, QT interval is normal. Now, after you write this, then you come to the ECG diagnosis. So we said the learning of ECG is to one, identification, and the second is the diagnosis. So then you write the ECG diagnosis as normal ECG. Okay, so this rigor of going through each aspect of ECG is fundamental for you to learn ECG interpretation. If you don't go through this throughout your life, you will be in confusion and you'll never be
Dr.
able to
Rajiv,
answer.
here, at the end of all that what you said, electrocardiographic diagnosis they must mention, and also try to add clinical diagnosis that you reached. Then that concordance or discordance of anything, you will note again and go back to read the electrocardiogram if there anything unusual. Thank you.
Yeah. So once you have written the ECG diagnosis, this is necessary for any investigation which you do. So whether you do ECG, chest X-ray, echo, you do the blood test. The question you ask yourself is, after you have done the clinical diagnosis and you have done an investigation, is the investigation concordant with your diagnosis? Is it fitting into your diagnosis, or it is not fitting into your diagnosis? If it's not fitting, either of them is wrong. Either your clinical diagnosis is wrong or your investigation is wrong. And you go out of the way to find out why exactly this discrepancy is there. Then when you try to find out that, you come to the right diagnosis. So now I know it, you might have enjoyed last 2 3 days listening to all this. It's like if, almost during our childhood we used to have burakata. Somebody used to come and then they used to tell some stories and all, and then we go back home and we are very happy that we heard that. So all this what we taught you last 3 days will be like burakata for you if you don't go back and then put it into practice. So how are you going to put this into practice? Today, the moment you go back after the class, you go to the hospital, at least one ECG, you take a piece of paper and write it down. All the aspects of ECG diagnosis, you write it down, and also write down the ECG diagnosis. Whether you understand, you don't understand, whether you are right or wrong doesn't matter. But going through that process of writing down each wave and writing down all the aspects of ECG description, if you don't do it today, even if you do it tomorrow, you will not remember ECG. You have to do it today, immediately after the class. So this experiment we have tried with everybody. Those who do today, they will remember for the rest of their lives. Those who don't do today, they will never remember today. So please make sure that you follow what we have told. Okay. So we'll tell you certain different descriptions just to tell you how you write it down when you go back. So the different ECG diagnosis could be normal, or say it is left ventricular hypertrophy with left axis deviation with left atrial overload. So the final ECG diagnosis, when you write down all the positive aspects of ECG diagnosis. You don't just tell one aspect and then leave it. So patient might be having an anterior wall MI, but patient also has a left atrial overload. So you write down anterior wall ST elevation MI plus left atrial overload. So all positive aspects of the ECG you are supposed to write, or the axis, whatever it is. Say another patient might be having left bundle branch block with a right axis deviation. Patient might be having a pre-excitation, WPW syndrome, and you might also want to tell from where that accessory pathway is coming. Patient might be having atrial fibrillation, might be having LVH also associated. So you say AFib with LVH. Acute anterior wall STEMI, non-ST elevation myocardial infarction, early repolarization. These are the different things which you might want to write down as far as the ECG diagnosis is concerned. So that is how you describe the ECG. So if all of you go back and read one or two ECGs today, from tomorrow what we'll do is we'll actually start showing you the ECGs, and you'll understand how to interpret the ECGs. I will make you read the ECGs. So come prepared from tomorrow. Don't try to run off, and don't try to stop logging in just because you have to read the ECGs.
Rajiv,
Sir.
Today we don't have the book reading because some problem with my computer.
Okay.
And then also just tell them that the present and futuristic interpretation of electrocardiogram will use artificial intelligence, which revolutionizes the interpretation of what looks like what we were missing all these years will now be transformed. Once that comes, they must be ready for it in future. Thank you.
Yes, sir. Actually, I think many of them will be very happy that we need not learn to read ECGs because AI will do that job for us. We used to get upset that we might lose our jobs. So what I'll do is then we'll, any questions, we can just start reading ECGs today itself then. So any questions? How to determine LVH and RVH in their respective bundle branch patterns? Okay, so that's actually an interesting question. There are certain criteria which are there in the presence of LBBB, RBBB. How do you identify whether there is associated ventricular hypertrophy or not? If it is obvious, that is, if it is fitting into the criteria of ventricular hypertrophy, In spite of having bundle branch block, then of course, you know that it is there, but it is not easy. You want to add something, sir, on that? How to determine LVH, RVH when
Just
there is
ask
bundle
them,
branch block?
Rajiv,
Sir,
the electrocardiogram is normal. Does it rule out severe underlying disease? Just ask them what they think. The
I think
electrocardiogram
all of you
is
heard that
normal.
question. Anyone would want to answer that question? Presence of a normal ECG, does it rule out a severe underlying condition? You need to tell yes or no. Okay, someone double one said never. Never, never. Someone said yes. Someone mentioned rules out atherosclerosis. So different ideas, sir.
Whenever you are asked what looks like, and the question is unusual, you always say it depends, sir. You should always say it depends, sir. So it depends upon the nature of the disease you are talking about. Whether it is congenital heart disease, whether it is structural heart disease acquired, whether it is coronary artery disease or metabolic abnormality, etc. So it depends upon the clinical situation and the clinical condition. Like, for example, you can have severe valvular heart disease, say like mitral regurgitation, etc., with otherwise what looks like normal electrocardiogram. So, but certain situations like it's highly unlikely you have a severe heart failure due to heart disease with normal electrocardiogram. There is at least STT changes will be there, RTO changes. So it depends upon the clinical condition. Should keep it in mind and be aware. Electrocardiogram normal doesn't rule out severe underlying heart disease. Somebody said atherosclerosis. Check active coronary artery disease or a large myocardial infarction, etc. But past myocardial infarction, small, healed up, or even acute coronary syndromes in the initial phases, etc. Serial electrocardiograms have to be done to rule out evolving acute coronary syndromes. So thank you.
Sir, you want to comment on that question about identification of ventricular hypertrophy in the presence of bundle branch? You are in mute, sir.
What is the question?
How to determine left ventricular hypertrophy and right ventricular hypertrophy in the respective bundle branch blocks?
So, bundle branch blocks have a widened QRS and slightly increased voltages. But anything more than that, if you see, say, an RBVB with a QR pattern, RBVB with STT changes in the leads that matter. Similar things apply to discordant STT changes or QRS abnormalities unusually more or unusually more indicates underlying hypertrophy. In addition, the accompanying P wave abnormality, P wave abnormality also helps you to know that there is underlying RVH. Or suppose you have an RBB with, say, P wave abnormality like right atrial enlargement or left atrial enlargement. Accompanying ventricular hypertrophy is likely. Similar thing applies to LBBB also. Then, in addition, you may have to combine clinical plus electrocardiogram pattern in certain situations, and it can be misleading sometimes.
Yes. Next question is new onset LBVB. Is it still considered a marker of ischemia or infarction? So unless proven otherwise, if you have a new onset left bundle branch block, you consider it as STEMI, as a ST equivalent, STEMI equivalent. So you treat them like a ST elevation MI, take off a primary angioplasty or give thrombolysis or whatever it is. If you are sure that it is a new onset LBBB, if it is not, then there are some criteria. We'll come to that about how you identify ischemia in the presence of left bundle. Yeah, Vamshi mentioned that triple vessel disease with balanced ischemia can show normal ECG. Then Garbosa's criteria will explain to you. The next presentation will be that only. Significant ST elevation and depression criteria. We'll come to that. So generally ST depressions, if it is more than 1 mm, when you talk about ST elevations, it depends upon whether it is you are talking about inferior leads or whether you are talking about anterior leads. So for you to diagnose a ST elevation MI, depending upon the lead where it is and the contiguity of leads, whether 2 leads or 3 leads, based on that you decide the extent of the diagnosis of ST elevation. So inferior even 1 mm is sufficient, whereas in anterior around 3 mm, at least 3 contiguous leads. Any other questions? So 111111, can you identify yourself for us? Who are you and you're from which college and what are you doing? Okay, Dr. Raman, you're doing MD General Medicine. You are from which college, Raman? Oh, from Pondicherry. Okay. So we'll Sri Venkateshwara Medical College Hospital. Okay, thank you. So what we'll do is there is a collection of ECGs, but before that, as you can see, many people have doubts about ST elevation, ST depression, Garbosa's criteria, and all that. So I will just tell you certain basic aspects of identification of ECG in myocardial infarction and ischemia, and what are the mimics which are there. So we'll start.
Ask them whether they now have a mental picture of their hexaxial reference system on their own body or a circle.
Yeah, what we discussed about the hexaxial system. Do you have any? Do you have some idea about it now? Do you feel comfortable, or you feel threatened by the hexaxial system? Comfortable.
Suppose now 7:45 is the time. The small hand and big hand, where are they? At 7:45. Tell me in degrees, not time. 7:45.
So 7 is which lead? 120. Very good. So small is 120 degrees. Yeah. And bigger one 180 degrees. So that's right. So AVF L1 negative will be the big arm, and the small arm is 120 degrees. Not bad, sir.
Yeah, good. Actually, next few weeks, remember not time on your say watch. Remember these degrees. Somebody asks you time, tell them in these degrees. Thank you.
You tell 120 by 180, something like that. People will put you in some mental hospital or something, thinking something has happened to this guy. Okay, so we'll just start with a case example. So this was Miss SR, 16-year-old girl. She was a polytechnic student, and then she had a syncope while trying to catch a bus. Then she was seen by a doctor, and she was sent home, saying that you're 16-year-old and you won't have any problem. She had a recurrence again. Luckily for her, always she had to run to catch the bus. Second time again she ran. She developed a syncope. She was seen by a physician. A ECG was taken. He said ECG shows some changes, but he said non-specific changes for a lady. So gave her some antacids and sent her back home. Then again she had a third episode of syncope when she came to the emergency. So then we took a ECG in the emergency, and this was her ECG. So would someone like to read this ECG? Anyone can read the ECG. Dr. Rahman, you would want to read the ECG? You can just unmute yourself and then.
Good morning, sir.
Good morning.
Sir, a normal standardization and it's normal axis
Yes.
showing normal normal QRS complex with the P wave preceding each QRS complex.
So what you do is you first tell P wave, PR interval, and then QRS. That will be better. So you
Okay,
won't miss the
normal,
orders. So P wave is
normal, and
PR
PR
interval is normal.
interval is normal, sir.
Okay. Then
QRS complex is also normal, arrow
okay.
QRS complex. Then showing diffuse ST segment depression, downsloping
Yes. In which
in
leads?
inferior leads,
So L2,
inferior and
L3,
lateral leads.
ABF. Okay, from V3, V2 onwards, V2, V3,
V3, V4,
V4,
V5.
V5, V6. So inferior as well as anterior leads, there is a ST depression. When you have such global ST depression, which other lead you would like to look at?
AVR, sir.
Yeah, very good. So you look at AVR. What does AVR show?
Showing ST elevation, sir.
So AVR is showing ST elevation. Okay, so you have a global ST depression and a AVR ST elevation. That means if you look at the heart, okay, the whole myocardium is now AVR is this way. So the whole myocardium is now ischemic. Okay, the whole myocardium is ischemic, which is producing ST elevation. So now with this ECG, she's 16-year-old. What would you like to do? Send her home, give antacids, tell her that you are a 16-year-old girl, don't bother, nothing will happen. What would be your next step? Admit the patient.
We should admit the
Okay.
patient, sir. Since she developed 3 episodes of syncope during exertion, she have to be admitted.
So what is your suspicion with this ECG? Yeah, whenever you have a global ST depression and AVR ST elevation, you should always suspect some kind of severe ischemia. And severe ischemia usually can be because of left main, or it could be because of a severe triple vessel disease. So why a 16-year-old should have this? That is a second question. But just because she's 16-year-old, you don't say that everything is normal and send her home. Okay. This can kill the patient, right? So then she was admitted. There was a suspicion.
Rajiv, they must also notice the increase in voltages satisfying the criteria for underlying LVH also. The Q wave is retained in V5, V6. The R wave is slightly taller than usual. In the differential diagnosis, hypertrophic cardiomyopathy also comes in. Though it's not there are some points against it, but it is you should not miss out the possibility of underlying LVH. But the pattern of LVH is also described with LMC abstraction.
Yes. So what does the ECG suggest? Non-specific changes, pre-excitation, pericarditis, left main stenosis. So AVR, ST depressions, and then you can see here the angiogram. So if you look at this angiogram, this is the left system. This is the catheter which we use to hook the left side. Now this is left main. This is what we call the left anterior descending, and this is the left circumflex. Okay, you can see this particular area, it is like a hair here, that area. Okay, so that is a very tight left main stenosis. So this is the normal width, and that has become like a thread there. Okay, so the same thing again in another view, where you can see that the same stenosis you can appreciate here. So this is the left main, that is the left main, and this is the normal width of left main, and you can see that there is a tight stenosis here. So this was a ostial left main tight stenosis, and this patient actually had a circumflex which is a dominant circumflex. That means more than 90% of her heart now is being supplied by this left main, which has a critical stenosis. So you might have heard about people who sleep in the night and then don't wake up in the morning. They have a sudden cardiac arrest at night. So these are the people, this is the type of disease which those people have, the left main stenosis, where when it gets occluded, within few seconds, they expire. There is a sudden cardiac arrest. So this girl had a severe left main stenosis, and this was the stenting which was done. And you can see that after stenting, that narrowing which we had mentioned. Okay, so now you can see that this width and here the narrowing was there. This width, both of them have become totally normal. And so this was a tight left main stenosis. Later, when we evaluated her, she had a condition which is called as Takayasu's arthritis. That is a vasculitis. So because of the vasculitis, now we know that the coronaries arise from the aorta. Okay, so you have the aorta and then you have the left main giving rise to branches and then the right coronary artery. So this aorta gets inflamed in aorta arthritis. So when the aorta gets inflamed, that causes narrowing of the left main there. So this was not because of atherosclerosis, which is common for coronary artery disease, but here it was because of vasculitis, because of which this patient had a severe left main stenosis. Okay. So what we'll discuss in this presentation is the recognition of ischemia infarction. What are the patterns, which some of the questions which we asked? What is the terminology which we use in myocardial infarction, and what are the ECG mimics for myocardial infarction? So I think we'll continue tomorrow. So
Rajiv,
sir.
This patient, if I remember, was seen not only by a physician or practitioner, plus even a cardiac center was sent away. What is the significance of this? A physician missing out the serious possibility of underlying disease and possibility of sudden death, and even a cardiologist missing out. What is the significance of this? Any one of you can answer. You can answer the next class also, tomorrow. Time.
Actually, during our time, when we used to attend Dr. Somraj's classes, and then if he asked a question like this, some of our friends used to say, "Sir, they didn't attend your classes, sir. That's why they missed." They learn to tell such things.
We'll discuss next class. Let them think about it.
Yeah. Okay. So I think we'll close the discussion here, so that so what you do is just read up about ischemia and infarction. If possible, one of the things which, though I mentioned to you the concept about current of injury, I'm sure many of you would want to know more about that current of injury. So we have an animation. Let's see if we can project it tomorrow so that you actually understand what is happening in ischemia and infarctions. Okay, so we'll close the discussion here, and thank you everyone for attending. Narasimha, you can go ahead and close the class.